Let's go over the warm-up review. First question, which serum lab marker is helpful in assessing the appropriate oxygenation of tissues? Well, it's lactic acid. If lactic acid is high, that suggests that the tissues aren't adequately oxygenated. Next, what are the 5 branches of the facial nerve? So the facial nerve is cranial nerve 7, and the mnemonic for the branches of it is to Zanzibar by motor car. So T is for temporal, Z is for zygomatic, B is for buccal, M is for marginal mandibular, and then the C is for cervical. The last one. What should be suspected as a cause of headache in a patient using topical retinoic acid for the treatment of acne? Well, this ought to make you think about idiopathic intracranial hypertension, or IIH, because retinoic acid is vitamin A, and vitamin A toxicity can cause IIH. Now, what's the old name for IIH? Pseudotumor cerebri. Now you're ready for the lecture.
Hello everyone, and welcome to our Step 1 video on genetic diseases, autosomal dominant, and trinucleotide repeats. Alright, so a blind man, a horse, and a luchador all go into a bar. Stop right there! Who are you? Well, I'm future you from, well, the future. Wow, I guess that's cool. I'm here to stop you from doing that bad joke. It's really bad. You're here for that? Shouldn't you use time travel to, I don't know, stop wars or cure diseases or something? Well, I could, but man, this joke is terrible. I mean, really amateur stuff. Okay, well, I guess that's about it. Oh, whatever you do, don't put a banana in your back pocket, March 2nd, 2021. All right, later, loser. Well, I guess I won't finish that joke then. Man, future me is kind of a jerk. All right, so we're talking about some genetic diseases today, and that can be a bit tricky because it's difficult to remember which diseases are autosomal dominant, which are autosomal recessive, which are X-linked, and unfortunately it's important to remember which ones are which. Now, I'm also going to sprinkle in this lecture some clinical scenarios to kind of spice things up as well. All right, so let's start with autosomal dominant diseases. A 52-year-old man presents with flank pain and gross hematuria for the past several weeks. On physical exam, his blood pressure is 160/100. Urinalysis reveals hematuria, and serum lab studies show a creatinine of 2.9. An ultrasound of the abdomen reveals bilateral enlarged kidneys with multiple cysts present. Cysts are also seen in the liver and the pancreas. What's the diagnosis? So this one's not too hard. This is autosomal dominant polycystic kidney disease. Now, you may have known this in the past as adult polycystic kidney disease, but now it's referred to as autosomal dominant. Now, this primarily affects the kidneys, but it can affect other organs as well, including the liver, the pancreas, the brain, arterial blood vessels even. Now, generally, you see enlargement of the kidneys due to multiple large cysts, and it's always going to be bilateral. Now, diagnosis is often made by CT scan or ultrasound. Patients present with flank pain, hematuria, hypertension, progressive renal failure. Now, the disease is due to a mutation of what's called the APKD1 gene on chromosome 16. It's also high yield to know that autosomal polycystic kidney disease is associated with Barry aneurysms. All right, so now let's move on to achondroplasia. So this is also referred to as dwarfism. So this is a defect of the fibroblast growth factor receptor, so also referred to as the FGF receptor number 3. And it's associated with advanced paternal age. So older men having children are more likely to have those children have achondroplasia. Now, it can be inherited as an autosomal dominant disease, but it occurs as a sporadic mutation in 75% of cases. Next, we have familial adenomatous polyposis. So this is where the colon becomes covered with adenomatous polyps after puberty, and it can progress to colon cancer unless those polyps are resected. So basically, these patients are going to have a colectomy or they're going to get colon cancer. Now, a mutation of the APC gene is responsible for this, and you can use the AD in adenomatous to help you remember it's autosomal dominant. Now, there are a few other genetically similar disorders that are associated with the APC gene mutation. So FAP is the first one, familial adenomatous polyposis. And then there's also what's called Gardner syndrome. Gardner syndrome is autosomal dominant. It presents with polyps in the colon as well, but also tumors outside of the colon. I think of kind of a gardener growing lumpy vegetables. I don't know, some crazy looking squash. Well, this is a syndrome where you grow lumpy and bumpy all over from a lot of different things. So Gardner syndrome will result in osteomas, in lipomas, in sebaceous cysts, colon polyps, and then colon cancer develops later in life as well. All right, so now we have another scenario. A 22-year-old man presents to the ER with chest pain and shortness of breath for the past hour. He has had progressively worsening dyspnea on exertion for the past several months. His ECG reveals ST segment elevation in multiple leads, and his troponin I is elevated. On exam, his heart rate is 110, respiratory rate is 25. He has yellowish papules on the medial side of each upper eyelid. What is the primary cause of this patient's myocardial infarction? Well, this is going to be familial hypercholesterolemia, and this is going to be type 2A hyperlipidemia. So the LDL becomes markedly elevated because of a defective or absent LDL receptor. It's not very rare to be heterozygous for this disorder, but homozygous is different. Patients will have LDLs above 300. Homozygotes, which are very rare, as I said, have excessively elevated cholesterol, so that LDL over 700 even. A very severe atherosclerotic disease very early in life. So these patients will have tendon xanthomas, xanthelasmas, that's that yellowish deposit of fat under the skin around the eyelids. And unfortunately, these patients will have potentially myocardial infarctions even before the age of 20. Moving on to hereditary hemorrhagic telangiectasia, also referred to as Osler-Weber-Rendu syndrome. So this is an inherited disorder that leads to abnormal blood vessel formation in multiple areas, the skin, mucous membranes, and in organs as well. So imagine what that might cause: telangiectasias, recurrent epistaxis, skin discolorations, AVMs, chronic GI tract bleeding as well. Now, a student suggested that we call it a Schnosler-Weber-Rendu to help remember that it causes a lot of nosebleeds. All right, another scenario. 25-year-old woman comes to the physician for fatigue and skin yellowing. She reports that she's been anemic in the past, but she's never felt this poorly before. She had a viral illness 1 to 2 weeks ago. On exam, her heart rate is 120, her skin is jaundiced, serum analysis shows hemoglobin of 8.1, a mean corpuscular volume of 85, and a mean corpuscular hemoglobin concentration of 39. And now an osmotic fragility test shows increased cell hemolysis. What's the diagnosis? This one a little tricky. A little vague also because I left out the peripheral smear, which would actually just kind of give this away, which would show the round-shaped red blood cells. So this is going to be hereditary spherocytosis. So instead of having the normal biconcave shape of red blood cells, you have spheroid erythrocytes, and they're just kind of circular big fatties erythrocytes due to a spectrin or an ankyrin defect. Remember that, spectrin or ankyrin. Spectrin and ankyrin provide the structural framework of the red blood cell that allows it to have a biconcave shape and allows it to be kind of flexible and be able to move through capillaries. Well, if it can't do that, you're going to increase the viscosity of blood. So these sphere-shaped cells are also more prone to hemolysis. Therefore, it can result in hemolytic anemia and jaundice. The hemolysis can worsen with viral infections as well. MCV tends to be normal or slightly low, so that it's not much of a help for diagnosis. The MCHC is going to be elevated. So what is the MCHC? Well, it measures the concentration of hemoglobin in a given volume of red blood cells. Now, this elevation in the MCHC is reflecting membrane loss and red cell dehydration. Well, how do we take care of this potentially? Well, one reason why you have hemolytic anemia is because your macrophages in your spleen are identifying these red blood cells as abnormal and they're removing them from the circulation. So you can improve this by removing the spleen. And then these red blood cells are allowed to exist a little bit longer and the risk of anemia decreases. And how do we diagnose this in the first place? Well, the diagnosis is made by pretty easily by that hemolytic anemia, the spherocytes on the peripheral smear, and an abnormal osmotic fragility test. Now, these red blood cells are more susceptible to osmotic damage and osmotic induced lysis other than other biconcave normal red blood cells. So next, let's hit Huntington disease. So this is a neurodegenerative disorder that affects muscle coordination and also results in cognitive decline and psychiatric problems. So patients will have depression, progressive dementia, the core form, the very wild movements, and caudate atrophy. And also you're going to see a decreased level of GABA and acetylcholine in the brain. So you try to remember the C's of Huntington disease. That's how we're going to remember this. So they include cognitive decline, caudate atrophy, chorea, the CAG repeats. So this is a trinucleotide repeat disorder as well. And then we start to reach a little bit further after that. There's the C for chromosome 4, so chromosome 4, C for 40, which is the typical age of presentation, around 40. And then decreased acetylcholine is another way to remember that well. So we're stretching just a little bit. Remember all the C's for Huntington. And then we have Marfan syndrome. So this is a connective tissue disorder affecting the skeleton, heart, and eyes. Patients are tall, very long extremities, and this is due to a fibrillin gene mutation. Patients will present with pectus excavatum, hyperextensible joints, long fingers and toes, so we call that arachnodactyly. Patients may also develop cystic medial necrosis of the aorta, which can lead to aortic valve regurgitation, even aortic aneurysm and dissection. You also have a very floppy mitral valve, which can lead to mitral valve prolapse. Subluxation of the lens is pretty unique to this situation, and it's associated with Marfan. In the past, it was thought that there was an association between Marfan and Berry aneurysms, but new evidence suggests that's probably not so. Let's move on to the multiple endocrine neoplasias, so MEN. MEN1 or MEN2 are disorders that predispose patients to tumors of many of the hormone-producing glands in the body. Now, we cover this in more detail in the endocrine section. These are autosomal dominant, but let's hit them a little bit here. So MEN1 is associated with the MEN1 gene. MEN2A and then there's MEN2B. Those are associated with the RET gene mutation. So again, each of these will feature different tumors of the endocrine glands. And there's a kind of nice mnemonic here to remember the tumors that are associated with each of these. So with MEN1, think of PPP. So that's going to be for parathyroid adenomas. So you could actually get some hyperparathyroidism with that. Also, pituitary adenomas is the second P, and the third P is pancreatic tumors. And then there's MEN2A, so that's going to be PPM. So we're adding an M on this one. So it's going to be parathyroid adenomas, pheochromocytoma, and medullary thyroid cancer is the M there. And then the MEN2B is PMM, so we're replacing another P with an M. And that's going to be for pheochromocytoma, medullary thyroid cancer again, and then mucosal neuromas is the last one. Let's move on to neurofibromatosis type 1, also referred to as von Recklinghausen disease. So this is autosomal dominant again, and it's caused by a mutation of a gene on chromosome 17. So this gene is responsible for control of cell division. Without that control on cell division, we see tumors in the nervous system. Now, the symptoms include the café au lait spots, very important for this one, pigmented macules, and neural tumors. You also have what's called the Lisch nodules, which are pigmented iris hamartomas. And patients will also develop scoliosis as well. All right, so another clinical scenario. A 20-year-old man presents with hearing loss, tinnitus in both ears, decreased vision, and several hyperpigmented skin lesions. On exam, he has difficulty with cerebellar testing, he has bilateral cataracts, decreased hearing in both ears, and then you do see 4 hyperpigmented macules on the arms. What is the diagnosis? Well, the key to this one is the bilateral ear involvement. So this is actually neurofibromatosis type 2, and this can be associated with bilateral acoustic neuromas. So these are generally benign brain tumors in the region of the cranial nerve number 8. Therefore, you can expect patients to have a lot of hearing loss, tinnitus, balance problems. So it's associated with a mutation on chromosome 22. A good way to remember this one is that there are a lot of 2s. Neurofibromatosis type 2 on chromosome 22, and it's bilateral. Patients may also develop cataracts, other neurologic tumors, and cutaneous manifestations. Moving on to tuberous sclerosis. So this is a result of a mutated hamartin or tuberin gene. This results in non-malignant tumors in the brain and on other organs. Facial lesions are common, which are called adenoma sebaceum. Patients will have hypopigmented ash leaf spots on the skin. You can have cortical and retinal hamartomas, you can have seizures, you can have intellectual disability as well. It's also associated with cardiac rhabdomyomas and astrocytomas. A lot of stuff on this one. Next, we have von Hippel-Lindau disease. So this is, again, an autosomal dominant disorder that predisposes patients to multiple types of tumors. So patients will have hemangioblastomas of the retina, cerebellum, and medulla. About half of the affected individuals develop multiple bilateral renal cell carcinomas and other tumors as well. And one of the other tumors is going to be a pheochromocytoma as well. Now, it's going to be associated with deletion of the VHL gene, kind of fits with von Hippel-Lindau gene. Now, this results in expression, though, of something called HIF, and that's going to be a transcription factor that leads to activation of angiogenic growth factors, which is why you have all these hemangioblastomas. All right, so we're finally done with those autosomal dominant diseases. Let's move on to the trinucleotide repeat diseases, and there's 4 that you need to know about. First, there's Huntington, and we actually already mentioned this one earlier, and that's that CAG repeat disorder. We're not going to talk about it again. But remember, C for Huntington's has a lot of C associations. That CAG is the actual repeat. Myotonic dystrophy is another one, Fragile X syndrome, and then we have Friedreich's ataxia. So what do all of these disorders have in common? They have the 3 nucleotides that continually get repeated in the human genome. And for each generation, more and more of these repeats come about, and it causes lots of problems. Now, genetic anticipation is a result of this, and as a consequence, either the disease severity increases or the age of the disease onset decreases with a successive generation. So you get younger and younger when you start seeing symptoms. All right, so let's go ahead and talk about Fragile X syndrome. So this is an X-linked disorder, and it's a trinucleotide repeat disorder. So the repeated 3 nucleotides are CGG. Now this is going to affect the expression of the FMR1 gene, and the way I remember this is I think FMR, fragile mental retardation, because Fragile X can cause mental retardation, or what we refer to now as intellectual disability. It's one of the most common causes of intellectual disability, but you need to take it to the next step. You need to know what the gene does, and it's a gene that codes for FMRP, which is a cytoplasmic protein found in the brain and in the testes, and it's involved in mRNA translation of axons and dendrites. It is the second most common cause of genetic intellectual disability, as we mentioned, and third most common overall. So fetal alcohol syndrome overall is the most common, Down syndrome, and then Fragile X syndrome. So findings, macroorchidism, so enlarged testes, which makes sense because we mentioned that FMR protein is found in the testes and again also in the brain. Patients might also have long faces with large jaws, large everted ears as well. Mitral valve prolapse is also common in this disorder. Let's move on to Friedreich ataxia. So what is Friedreich ataxia? This is an autosomal recessive disorder and again a trinucleotide repeat disorder. The repeated trinucleotides here are going to be GAA. Now with Friedreich ataxia, the gene that's problematic is the gene that codes for a protein called frataxin, which is a mitochondrial protein that deals with iron detoxifying and storage. Now, the primary pathology is degeneration of sensory neurons, but it also causes hypertrophic cardiomyopathy and diabetes mellitus. Patients will have a staggering gait, frequent falling, nystagmus, dysarthria, pes cavus, and hammer toes. Now, this presents in childhood potentially with just kyphoscoliosis. All right, that's it. It's time for the end of session quiz. Try to answer those questions on your own, and then we'll go through them together. First question, what genetic defect is responsible for achondroplasia? Well, there's going to be a cell signaling defect of FGF, the receptor, which is that fibroblast growth factor receptor. Next, we have a genetic defect in which proteins result in hereditary spherocytosis. Remember that defect is going to mean those proteins spectrin or ankyrin. So this defect causes spherocytosis and that hemolytic anemia. Next, what autosomal dominant disease fits each of the following statements? So a big review here. Associated with floppy mitral valve, dissecting aortic aneurysm, think of Marfan syndrome. Associated with mitral valve prolapse, liver disease, and Barry aneurysms is going to be autosomal dominant polycystic kidney disease. Neural tumors, pigmented iris hamartomas, that's going to be neurofibromatosis type 1. Very strong association with colon cancer. That's going to be that familial adenomatous polyposis coli, or FAP. Remember, it's that APC gene mutation. MI before age 20, that's going to be familial hypercholesterolemia. Hemangioblastoma of the retina, cerebellum, and medulla, that's going to be the von Hippel-Lindau. Increase MCHC in hemolytic anemia. Again, think about hereditary spherocytosis. Bilateral acoustic neuroma, so you're going to have that hearing loss. That's going to be a neurofibromatosis type 2. Facial lesions, seizure disorder, and increased cancer risk. Think of tuberous sclerosis. Caudate atrophy and dementia. Remember all the C's of Huntington disease. Cystic medial necrosis of the aorta. That's going to be Marfan syndrome again, and that can lead to aortic dissection. And then a defect of fibroblast growth factor receptor 3, achondroplasia. All right, next question. What are some of the disorders resulting from trinucleotide repeats? So there's Huntington disease, which is a CAG nucleotide repeat disorder. We also have Fragile X syndrome, Friedreich ataxia, and then myotonic dystrophy. All right, guys, that brings us to the end of our video. I hope you learned something. I'll see you next time.